of diseases that go in that sense. We have Parkinson's, Huntington's, Alzheimer's, multiple sclerosis. Are you familiar with any of them? Alzheimer's is very famous. I think Parkinson maybe somehow. Have you heard of multiple sclerosis before? Multiple sclerosis is one of those diseases that usually affects the person suddenly and without any previous warning, and the person will start losing their vision, losing their ability to walk. It's an autoimmune disease that causes degeneration in the brain. Anyways, there are many common things between those, and mostly it's all related to the brain being, or the neurons being slowly degenerated. So it tells us something about the progression of the disease. Do you think it's so fast or it's slow? It's slow, exactly, because the neurons take time to degenerate. And so starting with Parkinson's disease, this is what a person with Parkinson's looks like. So a person with Parkinson's disease is a person who is very slow, right? So you want to think about a person who, for example, when they want to move from here to there, it takes them so much time. Okay, so this is what we call as bradykinesia. Okay, so brady, that's for slow, like for example, bradycardia. But here it's bradykinesia. Okay, kinesia is for movement. The person's muscles would be rigid. What do I mean? You know when you walk, how do you walk? You walk in your hands or it's moving. People with Parkinson's, they walk in their hands are like this. These are very stiff. And their posture would be inclined, so they have their axis would be like this. Okay, so they have a stooped posture, all right? In their hands, they have a shaking. And that shaking happens when their hands are relaxed, so they're not kind of doing any movement. Usually whenever, for example, if they want to do something like a very fine movement, let's say they want to buckle a bottle, like this, so whenever they're doing this fine movement, the shaking would stop. Okay? But the shaking happens when they're at rest. Okay, they're holding something, the hands might shake as well. Okay, but usually when we're talking about something that requires some fine movement, because other centers of the brain will be activated, so this means that they can do it. Okay?
But isn't that at the early stages of the disease? But
at some point, they might also lose this ability to control their tremors at some point. So, tremors is the only thing that happens faster. Everything else, the person will be so slow, they will not have balance, they will be so rigid. Okay, so it's all related to this. And also they have their face is, we call it a mask face. So they have a mask-like facial expression. So their face, they don't do any expressions because it's the muscle rigidity part that affects their face muscles as well. So they're very rigid. Okay? Now these are the major features of someone who has Parkinson's disease. Okay, now speaking of clinical manifestations, the slide has too many information. Let's talk together about what can happen. And not everything here like I want. So let's take notes from what I'm saying. So what is the main neurotransmitter that is affected in Parkinson's? We talked about dopamine, exactly. So dopamine is the major thing that's affected. Is it higher or lower? No. It's lower in the brain. Actually, the neurons that make dopamine are the neurons that get degenerated. So slowly with time, dopamine is going to decrease at some point, okay? Do we only have these symptoms of movement? No, we also have things that are non-motor. When I say non-motor, that means it's not related to movement. Exactly, not related to movement, so non-motor. Like for example, anosmia, some people might lose their ability to smell. Okay, so they might go into psychological symptoms. Okay, so psychological, behavioral. Okay, they might go into things that, for example, they cannot sleep. Okay, so they go into other symptoms before the motor symptoms start appearing. And the motor symptoms start appearing very slowly, right? So this is where things happen. So things happen usually in something called the nigrostriatal pathway. This is a part of the brain. Anyways, I'm not going to ask you about this in details in the exam. Okay, but anyways, just know the following. It's the way the basal ganglia works. This is the basal ganglia over here inside of the brain. Okay, it's just all of these are connections in neurons that are required for function. And at the end of the day, when the basal ganglia is here, it sends an order to the cortex. You know the cortex, it's outside layer of the brain, and cortex is where the execution happens. So if I'm moving, this is because my cortex told me to do so. But the cortex is just do, نفذ ثم عمل, so just do, okay? But where does the analysis happen? In the basal ganglia. What do I mean? Yani now I want to hit the chair. Okay? I want to hit the chair with a file. This is a positive action, so I did something. Right? So this is an action. How did my brain know? Now I decided to hit the chair. My basal ganglia did the analysis, and this is a positive action, so I have to hit. And it sends a signal to the cortex, and the cortex then sends a signal to my hand, and then I get energy. Okay? If I want to hit hard on the table, okay, it will hurt my hand. So my body would know. Right? So I want to almost hit, I want to go like there, I want to stop here. Okay? What did my brain do? It made me stop. Okay, so I did not do a positive action, I stopped. This also is an analysis of the basal ganglia. So also the basal ganglia would know that I have to stop here. Okay, my body would have, if I wanted to do that, my body would have pushed the positive action. So guys, we have two types of actions. We have the direct pathway. For someone to be able to move, they have to be able to go forward and stop. Go forward and stop, right? So it doesn't make sense to only have one action. Otherwise, everyone would just be going forward. Okay, so your body is, or your brain will tell you to go into a direct pathway, which is excitatory, which is an action, and with nowhere to stop. And this is part of the analysis, which is the indirect pathway, or the inhibitory, which decreases motor function. Patients with Parkinson's, they have these messed up. Okay? Patients with Parkinson's, they have the direct pathway, the excitation is impaired, so they don't know how to go forward. This is why they're slow. And the indirect pathway is there. So the body is always in a stop mode. This is why the person is slow, there's postural imbalance, there's rigidity, so all of these actions together. But I'm going to ask you if there are tremors. What are these things? Let me tell you. So, dopamine is related to those. The person will be slow, the person will be rigid. But there is another neurotransmitters that come in the picture. And that neurotransmitter is acetylcholine in the brain. Remember guys, always, dopamine and acetylcholine together are opposites. When dopamine is low, acetylcholine is high. The opposite is true. So, because acetylcholine is high in the brain, and this comes or is happening in the area when there is movement, the high acetylcholine is actually what causes the tremors. Okay, so it's dopamine indirectly. So dopamine being low, because acetylcholine is high, and this is what causes the person to have tremors. But dopamine itself is linked to those pathways, and the person eventually will be slow. Makes sense? Are you understanding? Do you have any questions? You good? Okay, so this is it in a nutshell. And this is more complicated. This is about a number of neurotransmitters together, but I'm not going to go into the details. Not necessary. No, it's not necessary to go into the details. I just want you to understand what I mentioned. If you're interested to know more, everything is written. I got you everything you need in details, and I'm ready to explain it, but if for the sake of time, if this idea is complicated, then I don't think it makes sense to general. Alright? Okay, so this is it for the pathophysiology. Now, how do I want to solve the issue of Parkinson's? So what do you think is the approach? What do I want to do with the neurotransmitters? More dopamine, so this is a major thing. And if I want to control the tremors, I want to give something less acetylcholine. So I want to target dopamine in a way to increase it, make it appear more active. And I want to increase acetylcholine to control a part that is related to tremors, right? All right. So there you go. These are all the classes. I'm going to write them down all, and then we're going to go through the slides, okay, to make things more obvious for you guys. Then, first, I want dopamine. That? Why don't I inject dopamine? I'll have a pill of dopamine. Because dopamine cannot cross the blood-brain barrier. So we agree that dopamine is not an option. حتى dopamine itself So dopamine injection is not an option. Hatta dopamine as a pill is going to be broken down in the intestines. Nothing will happen. As if the person haven't taken dopamine at all.
Injections instead of drugs.
It makes sense, but imagine that you have a patient and every day you have to come back with another injection. It would be too much. Plus, that kind of injection does not exist. You don't ever do injections in the brain. So it's damaging to the brain, damaging to the scalp. We have better ways of getting dopamine in the brain than that. It's science. How are you going to do it? Not yet. We still have so much to do to get to the idea of injecting something in the brain. Anyways, so what is another approach? They said, why not I give a precursor that can be turned into dopamine in the brain. In this case, this is L-DOPA, or levodopa. Okay, so L-DOPA is what? Do you remember the pathway? We talked about it in adrenergic neurons. If you don't remember, just go back to it at some point when you're studying. Just take it, read it again. We have tyrosine, which is an amino acid. Tyrosine is turned into L-DOPA. L-DOPA turns into dopamine. In dopaminergic neurons, if this is norepinephrine, dopamine can be turned into norepinephrine and norepinephrine. Okay, norepinephrine. Anyways, this is the dopaminergic neuron. There's no need to continue the pathway. So if I'm giving levodopa orally, a pill, levodopa can easily go across the blood-brain barrier because there's a transporter for it. Okay, and it can go, and in the brain it will be turned into dopamine. And this way, what are we doing? We're making things better for the patient. We're increasing dopamine in the brain. Where does this happen? Inside the neuron. Makes sense? This is where all the synthesis of neurotransmitters happens, inside the neuron. Okay. What are some problems that can come with this topic? Oh, before we get there, let's also describe the other way. So we did add dopamine to the brain. The problem with this, that remember, they're happening in the neuron, and the neurons will start degenerating, and this conversion is going to be hard over time with an advanced disease. So I need to come up with other ways. So how do I make, or as if dopamine is working better in the brain, what other things I can do?
Dopamine agonist.
Excellent, dopamine agonist. So why not activate the receptors? So I have dopamine agonist. Excellent approach. This is one of the major drugs that we use. Okay, so number one, L-DOPA. Dopamine agonist can also be another drug that we use. Okay, let's try to think about enzymes. What? Yes, exactly. We can inhibit the enzymes. Like what, for example?
MAO and COMT.
Excellent. MAO and COMT. Okay, so I'm going to tell you how to use them differently. MAO or COMT, which one is stronger?
MAO.
MAO. So MAO inhibitors. We have two types of MAO. We have MAO-A and MAO-B. MAO-A is norepinephrine, the ones we learned about earlier. Dopamine is MAO-B. So I have MAO-B inhibitors will inhibit the breakdown of MAO, of the dopamine, and then dopamine will be high in the brain. Excellent. There you go. Now you said multiple pathways exist. Okay, so let's start. Let's see, guys. So levodopa, when you give levodopa in the intestines, it can go to the brain, and levodopa can be turned into dopamine. Okay? We can also have agonists for D1 and D2 receptors, and we can have inhibitors of MAO and COMT. Those are the main pathways. But there's one more drug that they found by chance that it is good for Parkinson's. We're going to talk about it in the next slide. Okay? Now, let's first start with levodopa. The idea, guys, of levodopa is easy. Let's see how many people joined so far. I have only one person. Hadi, they're gonna regret it because it's a quiz next week. Okay. So, guys, are things good so far?
Yes.
Okay. All right. So when we talk about levodopa, there are multiple things that make sense that we just want to think about to make sure that I'm delivering the most amount of levodopa to the brain. Okay, so levodopa
want it only in the brain. Do I want it outside the brain?
No.
Doesn't make sense. Well, guess what? Levodopa being transformed into dopamine outside the brain is not something beneficial because dopamine, what does it do? Dopamine cannot cross. Masato is trapped outside the brain. It's number one. Number two, dopamine itself has an effect on vessels. It causes vasodilation. So what does it do to blood pressure? It decreases. What does it do to the heart? Excellent. Reflex tachycardia. So it has some of these effects. So the patient will start suffering from symptoms. So I don't want this to happen. I don't want the levodopa to be transformed into dopamine outside the brain. Okay, so I use something that can inhibit the enzyme that turns levodopa into dopamine outside the brain. And that thing is called carbidopa. So levodopa is I want it in the brain. How do I stop it from being converted outside the brain? By using it in a combination with carbidopa. So guys, as a rule, always levodopa, carbidopa, always given together. Right? This is the first approach. But sometimes there's something else that might happen. There's another enzyme that you all know of that's called COMT. Even if all levodopa goes to the brain, what will COMT or what can COMT do? It's going to deactivate it, turn it into inactive metabolism. Is it something also favorable in this case? Not really. Okay, so in this case, what do I want to do? Inhibit COMT inside and outside the brain, both of them. What am I doing to levodopa? Keeping it as it is, without being degraded, leaving it to be available in the brain, and in the brain it will be converted to dopamine. Make sense?
Yes.
Right, so these are usually what we use. So for COMT inhibitors, we have two drugs. We have entacapone, and we have another one, that's not the best one, that's called delcapone. Make sense? So this is the approach. And the approach is written here, you guys. Okay, so this is an introduction. It tells you that levodopa is turned into dopamine in the dopaminergic neurons. And dopamine itself cannot cross the blood-brain barrier, things that we just mentioned. But L-dopa can be crossed by the central nervous system, and it will be converted to dopamine. And this is the most effective treatment for patients who are older than 65. Then, we just also mentioned that levodopa will be used with two drugs. What's the first drug? This is carbidopa. What is the job of carbidopa? Inhibit the enzyme that converts L-dopa to dopamine outside the brain. And we inhibit also what? COMT, which turns L-dopa into inactive metabolites. So I'm preserving L-dopa. All right. So what are the adverse effects? Guys, there's some adverse effects that are common for everything that can increase dopamine in the brain. Like what? Let us see. So the first one is when dopamine is high in the periphery. So see, we talked about this tachycardia and orthostatic hypotension. So we did mention this earlier. But this is solved with carbidopa because with carbidopa, the dopamine will not be high in the periphery. It will be only high in the brain, which will save the issue. You follow? Okay, very good. Yeah, let's continue. So what are the problems that can come with dopamine very high in the brain? Do you know what disease is linked to high dopamine in the brain? There's one disease that we haven't mentioned ever. I don't know if you know it from pathophysiology. Do you know schizophrenia with psychosis, all these diseases? Yes. Which they come because of high dopamine in the brain. Right? So hallucinations, patients when dopamine is too high in the brain, patients might suffer from hallucinations, confusion, psychosis, so they will have all of these effects. You know what hallucinations are? They start imagining things here and there that do not exist. Okay, so they will go into a mindset that is dangerous, right? And how do we solve the issue? Let's say the patient undergoes these, we have a drug, we have a treatment that's called pimavanserin. Pimavanserin is a drug that's given for psychosis that is because of levodopa. Okay? That pimavanserin is a drug that acts on a different pathway, a certain, not related to dopamine. Okay, otherwise, if you're inhibiting dopamine, you'll make Parkinson's worse. So this is why there's another pathway that that we feel the nausea and the sickness, this is in our brain, not in our stomach. Okay, so nausea and vomiting is a feeling here. So because dopamine, whenever it's high in this zone, the chemoreceptor trigger zone, this causes nausea and vomiting. Alright, so these are common. So any drug like dopamine agonists, I will ask, what are the side effects? You're going to tell me psychosis, hallucinations, and nausea and vomiting. It's common for all drugs that increase dopamine in the brain. Alright?
So how is it included?
What do you mean? It's when those centers in the brain gets activated, the person starts having feeling nausea and also vomiting.
So it's directly because of
This is why the drugs that have a good effect on decreasing nausea and vomiting if you have it are dopamine antagonists. Okay? Sometimes with levodopa, they're also said there will be some excessive dopamine in the brain, and this causes a condition called dyskinesia. So the person will be in the chair, and they will be like spinning around. They're moving involuntarily, so they have movement in their legs, movement in their hands. If you're interested to look at it, maybe there are so many YouTube videos that shows you how a person with dyskinesia looks like, somehow disturbing here. To see someone cannot sit in the chair, and it's something involuntary. The person cannot control it. Right? Now, there are two major adverse effects that are with levodopa. They're very well known. Levodopa is a very short-acting drug. Yeah, the patient has to take it more than one time a day. Okay? With time, what did we say happened to the dopaminergic neurons? They will get degenerated. Okay, so they will die slowly. So levodopa will not be enough. Yani the neuron made as little as this dopamine. And when we give levodopa, for example, let's say at 8 in the morning, usually, for example, for patients with good, the dose will last them for 4 to 5 hours and will not feel any symptoms of Parkinson. With time, the neurons are gonna be eaten away, degenerated. So, with time, the amount of dopamine that the body can produce from levodopa will be less. So instead of lasting, the dose can last for 6 hours, let's say, now the dose will last the patient for 2 hours. And after 2 hours, the patient will start having Parkinson's symptoms. And this is what we call as wearing off phenomenon. So the patient will start having Parkinson's symptoms again. Okay, and the patient will start feeling the symptoms until they take the next dose, when things get better, but it will last also for a short period of time, and the dose as if it wears off. So what is the solution for this? Number one, you can increase the dose, but not increase the dose at once. Increase the dose and the frequency. So instead of giving it every 6 hours, why not give it every 3 hours? Makes sense? So that eventually things are going to get worse. This is why one class of drug is not enough. You always sometimes have to add some classes. So you add some classes on top of this. Exactly. You add dopamine agonists. You might add for example, if you're not using a COMT inhibitor, entacapone, you want to use a COMT inhibitor. Makes sense? So you start moving things around with the treatments. You add treatments, you increase doses, you increase frequencies, you start these, you're going to take in pharmacotherapeutics diseases. So what you do in this case?
There's no solution for degeneration.
No. This is
It's gone.
exactly. So patients with Parkinson's, it's very hard to control the idea of degeneration.
So it's only the latent
Well, actually, it's not even the issue. It's just, this is all symptomatic treatment. We're just treating the symptoms. That's unfortunately. We have one drug I'm going to tell you that might have this effect of preserving neurons, but it's not that strong. But it's the only thing we have so far. Okay? So this is wearing off phenomenon. Do you understand wearing off? Okay. There's something also called on-off. What's on-off? From the name. On-off happens suddenly. On and then off. A patient might be moving, for example, patients with Parkinson's on levodopa might be moving, and then what happens suddenly? Basar, they feel like they want to turn. Okay, so they want someone call them from behind and they want to turn, they freeze. They go to like freezing episodes. Okay, so sometimes they freeze for a moment, and they sometimes need help in moving again, and then they will go back again to normal. So this sometimes happens, and this phenomenon, is there, and usually there might be not any benefit from any other medication to this symptom. So this happens in very late stages, and freezing episodes happen more frequently as the person progresses in Parkinson's disease. New formulations to help, sustained release formulations for levodopa, inhalation powder to help with these episodes. Okay, so whenever the person has these episodes, they might have this, for example, inhalation powder, for example. Okay, so we have some approaches that might be beneficial, but at the end of the day, the patient will have those symptoms. Right? It's not something that the patient will run away from. We try to solve them, but it's not optimal. Okay? There's no situation where we get rid of them for good, or no ultimate solution for all. You have any questions? Just remember, guys, levodopa I cannot give with MAO inhibitors that are the non-selective ones that we use for depression. So patients with depression might be taking this class of drug. If I give with levodopa, the person will have excessive neurotransmitters of dopamine or norepinephrine and all of these, and the person will have a hypertensive crisis. Okay, so I have to be careful for this interactions. That's it. Do you have any questions about levodopa? This is the most detailed thing. Everything else now is fine.
Can you just repeat the message?
Yes.
This one? Yeah. So patients with depression, some patients have depression, right? They start taking this class of drug sometimes. They're called MAO inhibitors. Okay. I haven't mentioned this ever so far. They were going to take in pharmacology too in depression. Let's say that person who has depression, who's taking this drug, also developed Parkinson's. So I have to give them levodopa with this class. This is a very serious interaction. I want to switch this drug to something else and then start levodopa. I cannot give levodopa with this class already. That's it. Make sense? All right. We talked about COMT inhibitors, and we said we have two drugs. Those are tolcapone and entacapone. Okay, we said entacapone has less side effects because entacapone is not associated with hepatotoxicity. What's hepatotoxicity? Toxicity to which organ? Liver, exactly. Whereas tolcapone is associated with hepatotoxicity. What are the possible side effects? Side effects of increased dopamine. So see guys, nausea, vomiting, okay, vivid dreams, hallucinations, confusion. And if it's outside in the periphery, orthostatic hypotension. Same thing as we mentioned for dopamine. All right? This is it that I wanted to know for this. Do you have any questions? Okay, so it's repetition of what I said earlier. Same thing. Same side effects, and we said those drugs will inhibit COMT. But guys, can I stop levodopa suddenly? Or any of the drugs that act on the central nervous system? No, I cannot. I have to stop it gradually or replace it with another treatment, okay? And if I stop it suddenly, what's going to happen? Something called the neuroleptic malignant syndrome. What is this? This is, when I say malignant, guys, doesn't mean cancer. It means something bad. Okay, so this kind of disease happens, and the person will suffer from confusion, so central nervous system effects. And he will suffer from rigidity in the muscles, so the muscles will be rigid, and their temperature is going to be high. And this is extremely dangerous because the temperature can reach very high values, and the person will start losing calcium, and it's a very complicated thing. So we just know that if we don't stop it suddenly, because it can be deadly. All right, so this is the take-home message from this slide. Now, dopamine agonists, from their name, but they do what? They activate dopamine receptors. Exactly. What are the possible side effects, guys? Nausea, vomiting, hallucinations. Same thing. With just one additional thing that they might cause fibrosis to the heart and the lungs. Okay, which can be not a very pleasant side effect. Okay? Now, what are the types of drugs we have? They come from ergot origin and drugs that are not from ergot origin. So we just divide them into their origin. The first one is bromocriptine that comes from ergot that has more side effects. And we have propinerol, pramipexole, and rotigotine, and those are the drugs that are non-ergot.
ergot شيء بيشبه القمح القمح
It's a problem.
It's a type, is a it's a type of plant. Botanically, it's not a plant. It's something else. But I forgot what it was. But there's something like that. Okay, but it's something else you can find. It's something that easy to find that you get these drugs. Maybe you can ask Dr. Samra. She's better than me. I'm not a big fan of plants and botany or pharmacology. Although in my community, you take pharmacology just one course. Pharmacology now. And with my education, we have 8 pharmacologists.
I'm too fed up with plants and pharmacology. Okay, what else do we use dopamine receptor agonists for? Something called restless leg syndrome. Now, guys, this is a condition where people can feel it. It's not dangerous, but if you haven't felt this before, you're not gonna understand the disease. Let me just try to explain it to you. So it's not a disease again, it's a condition. In patients, what they describe is usually it happens when they go to bed, when they want to sleep. They feel their legs, they cannot put them still. They have to move them because it's very uncomfortable. And usually any type of fabric will be very ticklish and will be bothersome for them, and they need to put their feet on something that's cold so that they get that relief. And usually it impairs their sleep very much. Yeah, if you want, it looks like this, but they can feel. They can feel the legs, but they feel they cannot move. They have to move them the whole time. They're very bothered. They cannot sleep. It's well the rest. They cannot rest. Okay, it's hard. It's hard to know what this symptom is or this syndrome is if you haven't had it once in your life. Usually patients might have this. You might have this once in your life, but you don't know that this is what's called restless leg syndrome. Okay, so if you have it, this is not dangerous. It can happen because of in women in pregnancy. It can happen if someone has anemia. It can happen. It can happen because of neurological damage and some diabetes. Any of these diseases just can happen. It's just like a symptom. It's not dangerous.
Is it the same reason with reverse increases in cholesterol?
No, not related to that at all. This can happen. This doesn't happen only in patients with Parkinson's. Anyway, but you can use those same drugs to treat that condition, to help the patients who have this condition. Okay. All right. Apomorphine. This is chemically related to morphine, but doesn't do the same thing. Guys, the only thing I want you to remember about apomorphine is 2 things. Number 1, when the patients take apomorphine, they feel very bad nausea and vomiting, so bad, that we have to give a person something for nausea and vomiting before the treatment and after the treatment. Okay? So apomorphine comes with a very bad side effect. That if it causes this bad side effect, why do we use it in the first place? And can I use it every day for patients every day? No, I cannot. It will cause vomiting the whole time. So when do I use it? I use it only in rescue therapy if a patient with Parkinson's has a freezing episode. When the patient with Parkinson's cannot move anymore, they're in bed, they cannot move, they have this freezing rigidity, and this is where I use apomorphine, and I can help the patient rescue. This is a rescue therapy. And what do I give? Before and after the treatment, something to help with their vomiting. Right? And this is what we call as antiemetic. Antiemetic is something that can help with vomiting. Okay? This is apomorphine. So guys, these are dopamine agonists. How many did we describe? Drug 2, 3, 4, and apomorphine. Alright? We're done with dopamine agonists. Now, MAO-B inhibitors. Remember guys, we said MAO-A and MAO-B? Which one is dopamine? B, MAO-B, exactly. MAO-A is not related here. Okay. What are the drugs? We have selagiline, prazosin, and safinamide. Okay, we have 3 drugs that we can use. Can we mix them with levodopa? Yes, we can give combinations here. That's normal. MAO-B inhibitors, I can give it normally with levodopa. So sometimes when the disease gets worse, why not think of combinations of drugs? Okay, later on in therapeutics, you're going to learn sometimes we can
Allergic agonists, we talked about something called tyramine. Tyramine is a substance in cheese. So whenever a patient eats cheese, usually tyramine is broken down because of MAO-A in the gut. So patients with depression, again, they have drugs that are MAO-A inhibitors. So when they eat cheese, will tyramine be broken down in the gut? No, because the drugs that for depression inhibit MAO. So the tyramine is not going to be broken down in the intestine. It's going to be absorbed. When tyramine is in the system, what does it do? It raises the blood pressure, increases norepinephrine. So normal patients will not suffer from this. The only patients that will suffer from this is patients who take MAO inhibitors. That's it. So patients with depression. But what about this MAO? MAO-B has nothing to do with the gut and tyramine and everything. So if we inhibit MAO-B, MAO-A is going to stay in the intestines, going to be break down tyramine, and we don't have a problem with cheese. So patients on these drugs will not have the cheese effect. Unless we're giving a very high dose that will start inhibiting MAO-A, then we would worry, but this is not an issue usually in patients with Parkinson's. All right? Now, we have a table of comparison. I only want one thing from this slide. When we compare selegiline and rasagiline, the main difference is in the metabolites. Selegiline has metabolites of amphetamine, and rasagiline does not have this metabolite. Why? What is amphetamine? Remember amphetamines? What do they do? Amphetamines, methamphetamine, crystal meth, all of these. These are, guys, central nervous system stimulants. There's addictive drugs. They stimulate the central nervous system. They cause anxiety. They cause all these side effects. So this is what I want you to know. Because of these metabolites, people will start having anxiety, insomnia, and other adverse effects. Whereas in rasagiline, this does not exist because the metabolites are not there. Make sense? Yes. All right, we're done with the 4 classes we mentioned. We did talk about levodopa. Let's revise together. We did talk about levodopa. What did we say we give with levodopa? No. Yes, so what do we need to give with it? Carbidopa, to prevent dopamine from being converted to dopamine outside the brain, and to inhibit COMT with intercapone. What are the major side effects with high dopamine? Nausea, vomiting, and hallucinations. Excellent. And dopamine outside of the brain, what does it do to the blood pressure? Decreases. Exactly. Decreases it. It causes tachycardia. Excellent. Okay. This is for levodopa. We have with levodopa 2 problems: wearing of phenomenon and on-off phenomenon. Excellent. This is levodopa. What about dopamine agonists? We said we have a bunch of drugs that are dopamine agonists. We have also apomorphine. What's the problem with apomorphine? A lot of nausea and vomiting. And why do we use it? As a rescue therapy. MAO-B inhibitors, do they have a cheese effect? They don't. And rasagiline and selegiline, we said selegiline has what type of metabolites? Amphetamine metabolites. Okay, this is? Yeah.
You say close to the house?
What is it?
Is it close to the house?
Tachycardia, reflex tachycardia. All right, we have one drug, guys, that's called amantadine. Amantadine is a drug that was used or is used as antiviral. It's used in viruses. But they figured out that it can help preserve the neurons of Parkinson's. This is the drug I was mentioning. Okay, so it is somehow neuroprotective, right? Amantadine, guys, is one of those drugs that might help patients preserve their neurons, help them somehow not go into fast degeneration. Okay, this is it. This is what's special about amantadine. And what are the side effects? We have some special side effect that is called livedo reticularis that appears in the picture. This is what the skin looks like. Okay, so this is called livedo reticularis. Usually this is what happens to the skin, and usually it comes with edema. Okay, some sort of swelling. Okay? This is it, what I want you to know about amantadine. So what's special about amantadine? It has this neuroprotective effect that is, it's limited, but it's the only drug that we know that might have this effect. Other treatments that we mentioned earlier are symptomatic, just to help patients in the rigidity and the bradykinesia and all of these, because they don't do much. Okay?
Good. So guys, remind me, what did we say about tremors? It's caused by what? Here we go.
Tremors are caused by what?
Acetylcholine.
Increase acetylcholine. So if I want to decrease tremors, what do I do to acetylcholine? Decrease it. How can I decrease acetylcholine or decrease the effect?
Beta 2. We take this.
Easier.
Selective. Not selective.
مش norepinephrine, acetylcholine. Got your point. This tremor over here is not related to beta 2. It's related to acetylcholine. So think of acetylcholine.
So guys, what we do is we use anticholinergic drugs that we talked about in anti-muscarinic effects. We talked about this when we talked about atropine, in the lecture of atropine. So we use benztropine and trihexyphenidyl. Okay? I'm not going to repeat things because we already have a lecture on this. So when you're studying, make sure that you just know that this is also used for Parkinson's disease, anti-muscarinic drugs. Why do we use them? To help with tremors and Parkinson's, the shaking of the hands. All right? This is it for Parkinson's. We're done. No? We're done. This is Parkinson's. Alzheimer's, I'm just gonna have 10 minutes to talk about. So let's rush and then we're gonna have a break, right? Yeah. We're done with Parkinson's. The good thing about Alzheimer's, you've taken all the drugs. You've taken them. Remember in choline esterase inhibitors? Yes. We said that some of the classes, one of the classes can be used for Alzheimer's. There you go. I'm just going to tell you what Alzheimer's is and the drugs you know. So that's it. Yeah, we're almost done. So guys, what is Alzheimer's? What is it? How does a patient look like with Alzheimer's? They forget. طب let's think about together what are the possible things that patients might forget in Alzheimer's. And at the beginning, do they forget everyone and everything? No, it's just slow, right? So the person starts forgetting. أول شيء they're at the end, advanced. But at the beginning, when the person, what are the first
الأشياء
symptoms?
البسيطة.
Yes.
مثلا ما نخلي الشيء.
Short-term memory, exactly. So they start forgetting what happened. مثلا, what did he eat today? What did he eat yesterday? They start forgetting very simple things, but they start also talking about things that happened in the past. So much. So short-term memory will be impaired, and long-term memory will take time. Usually, it even stays sometimes. So they think that they are stuck in the past, okay, in very deep memories. What else? At some point, patients will start forgetting roads and places. So they forget the directions. This road they usually take every day, and then suddenly they forget where's that location. And then they remember again. So it comes and goes, comes and goes. What else patients might start forgetting? مثلا, a patient might مثلا, be sleeping, okay, as a nap, afternoon nap. He took an afternoon nap, and let's say he woke up at around 6:30. They wake up, and they think now, okay, it's time for Salat al-Fajr. It's time to wake. It's now, they don't know that it's the dawn or the sunset. They can't tell the difference. For someone who's normal usually, or someone who doesn't have Alzheimer's disease, and even if you woke up and it was a very heavy sleep and it takes him 5 minutes, he will then figure it out, it's afternoon. Okay, but patients with Alzheimer's, and especially if there's a caregiver, so there are some family members who might have this problem with their, if it's, for example, a daughter taking care of her mother, and then the mother asks herself, well, where's the breakfast? It's been a while, we haven't eaten. They will have eaten lunch 2 hours ago, but it's morning, we haven't eaten for last night. Where's the breakfast? So there are things that are not only emotional for the patient, but emotional for their families. And this is where Alzheimer's gets heavy. At some point in advanced disease, people will forget pieces. Not only they will forget things, they will forget even simple things. A doorknob. Do you know how this works? You would know how to use this if it was like circle, if it was this. You know that this is the door and this is the doorknob. You're not going to be confused if it opens from here and here. Makes sense. The patients with Alzheimer's will not know that this is a door, this is a doorknob. They will not know how to open. And if, for example, like just use your ball, it usually makes sense. So guys, you all know that you open this way. Patients with Alzheimer's, if they open it this way, they will not know how to close it again. Okay, so
يعني يرجع عمرهم مثلا 4 سنوات لا
exactly, even worse. So they will forget even simple things. They don't know, for example, that this is food that to be eaten. Any food, a child who's 1 year old, they will know this is food, for example, or 2 years old, they will know this is food. They will know that this is eaten, a spoon is to eat. Patients with Alzheimer's will even forget this. Okay, so you start losing their function. They cannot go, for example, they cannot use or urinate on their own. They cannot use the toilet anymore. They need help and support on this. They will be bedridden. Their body will start losing function the whole time. Okay, so this is why it's a neurodegenerative disease. And it doesn't have a treatment. Whatever we're gonna say now is all symptomatic and it doesn't do anything. Okay? So patients with Alzheimer's, you guys, let me just show you the brain. So guys, remember guys, you know, it doesn't start suddenly, it's progressive. Yani patients will start asymptomatic, but things in the brain will start happening. Then the patient will have episodic memory loss. Yani every now and then, patients will start losing memory, but at some point they go into something called dementia. You know what dementia is? Dementia الخرف. Right, dementia is a big umbrella. Alzheimer's is one of the causes of dementia.
دكتور يعني مثلا إذا هم اكتشفوه فقط كلش مبكر عاملين بيقدرون ينسون الأشياء البسيطة راحوا للدكتور أو مثلا يقدر يقلل من الحالة يعني ما يوصلون لمرحلة إنه ما يعرفون الأكل.
Very good question, but progression is going to happen anyways. هلا, they might help with the symptoms, that could be, but is there a solution for Alzheimer's? No, not a solution. Come on. Not a solution for Alzheimer's. Until you're in section Sunday or Monday?
Monday.
Monday. There with you guys.
Yes.
Come in. We're talking about Alzheimer's.
بلشت الأعراض دكتور.
بلشت الأعراض؟ لا.
قبل جبنا السيشن.
احنا 9 with Parkinson's we started, but now we're going to continue with the other section with
إذا ولكن بالعشرة أنت لازم يقول واحد.
The other section, Ahmed is in section of Sunday.
Yes.
فأنا بعت له أتم لأنه we're going to start, هل they know this section.
واحنا بنأخذ عنه.
انتوا section تبعكم بالأتم بس. It's okay. Anyways, we have the session recorded. Did I record?
No.
I didn't record, y'all.
موجود بالسكشن.
بس السكشن الثاني they have half of the lecture. But guys, anyways, I'm ready to hop in case you need anything, you need me to repeat anything, we can manage with the other. But you can ask your friends. It's an easy lecture, no? Yeah, and it's relatively easier than all.
And it's small.
It is recorded. Very good. Someone recorded, and I did not record. Okay. All right, let's go back to patients with Alzheimer's. So patients with Alzheimer's, even though there's no treatment for the disease, we have the patients are going to progress, but we might help. And what did we say? In Parkinson's, it was about dopamine neurons. In Alzheimer's, it's about what type of neurons? Do you know? Acetylcholine. So what is the type of neuron that gets affected in what type of neurons gets affected in Alzheimer's? It's the neurons that carry acetylcholine. So what happens to those neurons? These neurons will start accumulating things. Neurons there shouldn't be any small particles inside of neurons. Other than the organelles, nothing. But there are things that start accumulating. So we have amyloid plaques. And we have what we call as neurofibrillary tangles. So there are things that start accumulating in the neuron. And when they accumulate, the body wants to get rid of those. So it gets rid of the whole neuron. Exactly, degeneration. Take a look at the brain of someone with Alzheimer's. It kind of shrinks, atrophy, exactly. So the neurons are atrophies. There's atrophy, not atrophy, it's like degeneration. Okay, so you see how the brain shrinks?
This is a patient with Alzheimer's. Okay, so at the end of the day, they have deficiency in acetylcholine, and acetylcholine is responsible in many places, responsible for memory. Okay, so what do you think is the solution to help patients? We want to do something to increase acetylcholine. How do I increase acetylcholine? Yeah, I might give agonists, okay, but we have better approaches because we increase acetylcholine everywhere. We use those, do you remember? Acetylcholine esterase inhibitors that we talked about earlier. So what are the drugs? We have three main drugs: donepezil, rivastigmine, and galantamine. Okay, I don't want you guys to know more than this. I know we took this before. You can go back to your slides to know all about the details of the side effects and everything. These drugs have many side effects, and you are responsible for those from the lecture here, not there, not in this lecture. Okay? We have one drug that could help a little bit with the degeneration. This is called memantine. Memantine is a drug that can help somehow. It acts on something that we call NMDA receptors. What is NMDA receptors? NMDA receptors is abbreviation of something very big. But they're receptors for what? Do you know glutamate? Have you heard of glutamate? GABA glutamate? Yes, those are neurotransmitters. Glutamate is excitatory. And sometimes we call it excitotoxic. It becomes toxic. So what we think, if we have something that is an antagonist to NMDA receptors, we might be slowing down the degeneration of cholinergic. Does it work this much? Not the best. But it is something that can help patients. Alright? So, what are the treatments? We have 4 treatments, these and this. And now guys, in trials, usually, we're very careful for any type of disease. You want to measure the risk-benefit ratio. So if there is, for any disease, any sort of treatment that has any side effects, we would be careful about using it. But with Alzheimer's, they're very, I don't know basis. Go with the treatment, even with high risks. Why? Because the patient is going to progress anyways. So why not try a treatment that is good, that might help? Okay, but the problem is that we don't really understand what's the solution. Okay, let me tell you about something that is interesting, and you can learn from how to look at science. Okay? Science needs a purpose, always. Science without a purpose, question mark. Like what, for example? There's a group of researchers from a very prestigious institute, very prestigious. They now can figure out if someone will get Alzheimer's 15 years earlier. There's a biomarker, a blood test, that they can do for simple blood test. They figure out the biomarker, they can tell the person that in 15 years you're going to have Alzheimer's. Okay. Very good, great achievement, they're brilliant, they did the best. Imagine if I tell someone, Alzheimer's, but he's like, yes, amazing, well, let's treat it. So you just have to be stressed for the next 15 years of your life, just waiting your destiny, and that's it. What's the purpose? If you don't have a treatment, what's the purpose of getting the diagnosis? It's worse, Let the person not know better.
It's a lifestyle.
Yes, but is it useful I mean, this can be in research, because why do I want to put it in the hands of patients? It's still too early.
But it can help them with research. Because not telling the patient, it's too early for it to be published.
Exactly.
But in research, it's a huge milestone.
Of course, but those were arguing that they want to put it in the hands of people so that people can know, because this is how they make money. Everyone will come and get tested. Okay, so this is the argument. So without the purpose, it's just disastrous. And it might be wrong. Any test in the world, there's something we call sensitivity and specificity. There's a chance that there are some false positive, the test is positive, but the actual result is not that. So it's false positives. So there's a big chance for any test in the world to have false positives. Simple. And at the end of the day, there's human error when you're dealing with simple tests. So they just can. All right, we're done. This is it. Okay. So, guys, you can read the question now. Okay, this is a summary. Okay, this is the same drugs, okay, that we mentioned, but this is what we talked about earlier. You can just skip this one. Okay? All good? So, guys, you can have a break if you want. And if you want me to summarize Parkinson's for you guys, I'm just keep right after before people show up. Amazing. Do you need more? I have a meeting at 11 and I need like 35, 40 minutes to explain the lecture at that to the guys. It's even maybe less, but maximum 30. So let's agree that you'll be back at 10:20. So if you want to have a break. So, very briefly, guys. Let's just.
Sorry, no, this will be continuing the lecture at 10:20.
Well, let me tell you, we are very busy. That when you really need to know what it is about. So, we're talking about neurodegenerative diseases. So, those are diseases where neurons. Exactly. So Parkinson's disease is, we said Alzheimer's is what neurotransmitter that gets affected? Acetylcholine. Here this is dopamine. So neurons that carry dopamine. Okay, so a patient with Parkinson's will look like this. They have their slow and everything, and they have tremors, shaking in their hands.
Parkinson's lab.
Okay. This is one of the symptoms, but the patients are slow. Very slow. They cannot move. They have this posture. Their face is rigid. Hatta when they walk, their hands are stiff like that. So they're very, very rigid. Okay, so these are the symptoms. It happens because of dopamine being low in the brain. But remember, guys, when dopamine is low, acetylcholine in the brain goes high, oppositely side. So when dopamine is becomes lower in this case, acetylcholine gets high. So dopamine, when it's low, it causes the person to be slow and everything. But when acetylcholine is high, this causes shaking. So if I want to treat the symptoms of Parkinson's, about slowness and everything, what do? I treat dopamine. What do I do to dopamine? I want to increase it. But when I stop the shaking, what do I do to acetylcholine? Decrease it. Control it somehow. So it makes sense to use anti-muscarinic drugs. Makes sense? Then when acetylcholine is high, I'm going to block the receptors. So to stop the shaking, I use anti-muscarinic drugs. So this is the last slide. I started from that. But for dopamine, what do I do to dopamine? I have many things I can do. So can I inject dopamine, give dopamine itself? No. Can it cross the blood-brain barrier? It cannot. So I cannot give dopamine. What can I give in this case? Something that will be turned into dopamine. And this is the first drug that's called levodopa. This is cancelled. Okay? Levodopa. Alright? Levodopa can be turned into dopamine in the brain. Do you think I want it to be turning into dopamine outside the brain? No. I want to keep it in the brain. So I give a drug that can inhibit this transformation outside the brain. And this levodopa is carbidopa. Okay, so I'm stopping L-dopa to turn into dopamine outside the brain. So what happens when dopamine is high outside the brain? What happens to the blood pressure? Decrease, it drops. Hypertension. When hypertension happens, what happens to the heart? Reflex. Yeah, it's right. Reflex. What else?
We have no dopamine in the brain. So what the drug?
I give levodopa. Levodopa will be taken to the brain and it will turn into dopamine. That's it.
Well, how about the body? You said something.
Do I want levodopa to be dopamine in the outside the brain? I don't want it. So I want to stop this. How do I stop this? I give carbidopa. Carbidopa will stop the conversion of levodopa, the dopamine outside the brain.
So I give like 2 drugs.
together, combination. Levodopa and carbidopa, it's like one is helping the other. Another question. There are enzymes that break down dopamine.
Yes.
Malcount. Remember malcount? What?
Okay.
No, trauma. I have worse trauma. And COMT, okay, COMT is one of the enzymes that can break down dopamine very strongly. So I inhibit COMT. When I inhibit COMT, what am I doing? I'm preserving the COMT. Okay, so I give a COMT inhibitor. What are the names of the COMT inhibitors? I have them. Entacapone, entacapone. They're written here. They're written somewhere. Entacapone, there you go. Entacapone, okay? Remember guys, entacapone doesn't have any problems in the liver. Entacapone will cause problems in the liver toxicity, cause problems. Okay? This is it for levodopa. Then what is the problem with high dopamine in the brain? It comes with side effects. Thanks, brain. What happens to dopamine in the brain what happens to the person when dopamine is high in the brain? Oh, well, she hallucinations. They start seeing things, hearing things, hallucinations. Number 2, nausea, vomiting. A lot of nausea. So these are 2 things that are common for anything that triggers dopamine in the brain, increases dopamine. So this levodopa is one of them. So this is a side effect of the time. If dopamine is high outside the brain, what did we say about blood pressure? What happens to blood pressure? It will drop and reflex tachycardia, which is what is. There are 2 things that can also happen to patients with Parkinson's on levodopa. Let me show you. There you go. On 2 phenomena. On our she is wearing off. She is on. What's the difference? Wearing off. Patients take levodopa. Let's say the patient takes 2 pills a day. At the beginning, the patient does not have any symptoms of Parkinson's, unless he's very good. At some point, the neurons will degenerate. So if the pill lasted the patient for 12 hours, now it's going to last them for 6. Not more. Okay, so nothing more than this. So what do we do in this case? This is what we call as wearing off. The dose does not last because of neurodegeneration. So what do we do to help the patient? High dose, and even better, I increase the frequency. So instead of giving it every 12 hours, the big dose, give it every 6 hours. If I was giving it every 6 hours, give it every 5, every 3 hours. Exactly, divide the dose more frequently during the day.
But then the neurons will keep degenerating.
Then you add the difference. Use the difference. This is the wearing off phenomenon. Now what about on-off? On-off means this, like a flip. Patient, for example, will be walking and they suddenly freeze. They go, Parkinson comes back, so. Okay? These are the 2 things that happen to them. This is it for levodopa. These are the main ideas. Okay? Let's skip down levodopa. COMT inhibitors, I just mentioned those. Okay? What else? And the dopamine agonists. We have multiple drugs, dopamine agonists. 1, 2, 3, 4. Okay? Again, what's the problem with dopamine high in the brain? What did you say about the side effects? Nausea, vomiting, what is hallucination. So same thing, guys. Nausea, vomiting, and hallucination.
Why do I need dopamine agonists in this case?
No, you either use levodopa or use dopamine agonists. Both are for them. You want more dopamine in the brain. So you can either increase dopamine itself or activate the receptors. Like this dopamine is there.
Because my main problem is low dopamine and high acetylcholine.
Exactly. So high acetylcholine, we learned how to solve this. We give antimuscarinic drugs. Low dopamine multiple ways. يا اما I give levodopa to be transformed into dopamine. يا اما I do the job of dopamine, which is this. Exactly. I have one drug that's special, apomorphine. Apomorphine has 2 things. Help me? You're on a break. Apomorphine has 2 things. Number 1, I don't use it a lot. Okay? Apomorphine. It's a rescue therapy. If I use it only for rescue therapy for freezing episodes of Parkinson's patients. Whenever the patient bedridden cannot move, I use apomorphine. But why is it not exact effective? Why don't I use it? causes a lot of side effects, vomiting, a lot of vomiting. So I have to give a drug against vomiting before and after the treatment. So strong. I think that's it for it.
دكتورة ما أريد أقاطعك بس
إيه.
السكشن الثاني موجودين بالتيم وأنت مو موجودة يعني
نهارين
يس
فينا نبعث اللينك. Do you want to send the link of this?
احنا عندنا بس
يلا ديا. Hey guys, so we're done with most. بعدنا واحد. Okay, so if I block MAO, what happens to dopamine? Increase. And this is another approach. عنا MAO B inhibitors. لأنه MAO B هو تبع الدوبامين. MAO A is for norepinephrine, right? Guys, أنا حأبعت للسكشن الثاني to section الأول يعني Sunday Tuesday to join the link. خلينا على اللينك الأساسي.
Don't they say the word makes you happy?
إيه. That's true.
There's nothing happy here.
100%. رح أقول لك شغلة دوبامين وسيروتونين واوكسيتوسين هو كلهم make you happy بس كل واحد in a way. دوبامين مسؤول عن الريورد سيستم. شو يعني ريورد سيستم؟ ريورد سيستم ليش هيدا عم يعمل هيك؟ ريورد سيستم يعني when you win something, when you get a high grade, when you يعني this reward, this very fast pleasure. Okay, so dopamine بيعلى وبيوطى بسرعة. It's not long-lasting pleasure. Oxytocin is connection between people. Okay, usually oxytocin is that connection. خليني ابعت. فيك تقولوا على الجروب Dr. Jana is sending you the link. Please join the link below. You did? Okay, thank you. مديرة الصف. لا مديرة الصف انت مش بدي تعملي ولا شيء. Serotonin is happiness. That's the way we think about it. So, yes, this is neurons are a complicated thing.
False information when people say dopamine.
Dopamine أكيد it gives you a very good feeling but it's like a roller coaster. يعني it's
They say sugar gives you dopamine. They say
ايه ما هو reward هيدا المكافأة which is very fast, increases and decreases.
but it's not constant.
Dopamine?
Like for example, I'm watching a good movie for 2 hours.
ايه لا 2 hours is fine بس مش عم نحكي long lasting effect. Serotonin is the happiness that is usually long lasting.
When you're having a good date,
It's usually dopamine أكثر reward linked to something that reward gives يعني dopamine هو serotonin is the long lasting steady happiness.
Doctor, your voice is too far. I
Yes?
cannot hear you.
Hi guys.
Your voice is too far. We cannot hear you.
I'm sitting right next to the laptop. Can you hear me?
Doctor, your voice
Yes.
is
Yes, but it's too far.
The problem is that I'm right next to the laptop the way I usually do. There's no noise cancellation on my microphone. Let me try to do something.
Hello, everyone. Good morning, doctor.
Good morning, doctor.
So I'm gonna try to hold my phone. All right. So now you can hear me?
Yes.
All right.
Yes.
So this session is going to be brief, but it is not opening. So let me just take a moment to try to share. It's not opening. Restarting the laptop. Guys, I'm restarting the laptop. Just give me a minute so that I can share the slides with you.
Okay, doctor.
Okay, guys, while we wait, let's have a chat about the topic we're gonna talk about now. So we still have two topics to talk about. The first topic we're gonna talk about now, which is sedatives and hypnotics, and we still have one last lecture about epilepsy that we're going to talk about next time. Okay, so starting off with the idea of sedatives and hypnotics. So what do you think about sedatives and hypnotics? What's the difference between sedation and hypnosis? So there's sedation and there's hypnosis. So what do you think, guys, the difference is?
Doctor, one of them is unconscious. Patient will be unconscious.
One is sleep, one is calm. Which one is sleep?
Yes.
Which one is calm? I'm gonna answer as well. It's we have some students with us in class, so maybe you will hear some people also talking. So which one is sleep? Which one is only being calmer? What do you think? Hypnosis or sedation?
The sleep, I think the sedation.
That's Mustafa. So Mustafa saying sedation is what? Sleep?
Yes.
Well,
sedation is calming.
Hypnosis. Hypnosis. Have you heard of hypnosis? This hypnosis is sleep. Okay. So guys, sedative is when someone is calmer. Okay. So I give a drug that is sedative. Usually I give it for people who are anxious. Okay, for anxiety. But hypnosis is when I want to put a person to sleep. All right. So this is when I want to treat usually insomnia. And there are a number of drugs that I use for this case. Like what? Tell me, do you know any sleeping pills? Anything? No? Panadol Night, excellent. So Panadol Night is one of the drugs that is seen as a sleeping pill, but it's actually Panadol Night. It's actually a side effect, exactly. It's an antihistaminic drug. Okay, so, but it is one of the drugs used for insomnia. But there are other stronger drugs. So guys, when we talk about sedatives and hypnotics now, bravo, benzodiazepine. Have you heard about this class before? Benzodiazepines?
Yes.
Did you take this in medicinal? Amazing.
Yes.
So benzodiazepines. Now let's talk pharmacology. You know now, Laini, you know GABA. Oh, hi guys, we need 15 minutes to finish the lecture. Okay, so benzodiazepines. Let's talk about pharmacy. Pharmacy. So in pharmacology, when we say benzodiazepines, what do you think? Is it something like I go ask the pharmacist to give me? Do you know any brand names of benzodiazepines?
Right.
تعرفوا شيء? Anything that's famous? Pregabalin لا pregabalin keep this للابيليبسي. Pregabalin ما له علاقة بالبنزodiazepines. Guys, you heard of Xanax? Benzodiazepines.
Yes.
Xanax, Revotril. Yeah, laptop is on. Revotril. شو اسمه there are many drugs out of my mind. Lexotanil. Do you know Lexotanil? Those drugs are controlled. يعني they usually exist when you go to the pharmacy. You're gonna find them locked in somewhere, and usually they should be not available for everyone. And they're addictive drugs with addictive properties. So benzodiazepines are not only for sleep, they're used for many things. Okay, like what? So for sleep is the first thing. For anxiety, some people have very long-lasting anxiety, so we can use benzodiazepines for that. What else? Do you know any of the other uses? Do you know what seizures are?
Antidepressant?
Antidepressant, abadan. They're not good for depression. And they might seem they're good for putting a person into a better mood, but no, they don't usually take the depression away. This is not usually the case. What else? Have you heard of seizures again, guys? They're used as anti-seizures. So benzodiazepines are very good drugs to treat epilepsy, to treat seizures. Okay, so they're one of the very good classes. And how do they act? They act on what receptor? GABA A. Okay, so GABA A receptor, do you know what type of receptor it is? It is it's an easier one. It's an ion channel. If it's an ion channel, it is a chloride channel. So when GABA opens, it allows chloride in, which is a negatively charged ion. So what happens to the cell? It gets inhibited, inhibition effect usually, okay? Yalla, very good. My laptop is almost on. I don't know what happened, but yalla, we're managing the lecture here. All right. So again, speaking of GABA A receptors themselves. So what do you think of benzodiazepines? Should they be agonists or antagonists? The receptor itself is inhibitory. So what do you think? They're agonists, exactly. So they're GABA A agonists, and they are allosteric agonists. What does allosteric means? Do they bind to the active site? No, they bind to the... Exactly. So this is the idea. So guys, there are two classes that we're going to talk about today that are GABA A agonists. Yes, Amir? Yes. It inhibits the cell that it sits on. Okay, and here we're talking about neurons in the brain. So they shut down the neurons. This is why they cause sleep, they cause sedation, they cause calming down. This is GABA receptors, exactly. So this is why in benzodiazepines, I give GABA A agonists. Amazing. All right, so this is the first class that we're going to talk about today. What are some of the uses of benzodiazepines other than being sedatives and hypnotics? They can also be used for seizures. Okay, so they're good for seizures. They do muscle relaxation. So when someone is having a very strong contraction of muscles, we can use it for skeletal muscle relaxation. What else are they used for? Their most famous effect is being used for sedation and hypnosis, akid, and for seizures. Right. For some people, we just talked about...
Anxiety could be...
I can't hear you.
Treat anxiety, maybe?
Anxiety, exactly. It's for treating anxiety. That's it. Okay. So this is the first class. Have you heard of barbiturates? This is the second class that we're going to talk about. So guys, barbiturates also work similarly to benzodiazepines. They're like almost very close the way they work. They're also GABA A agonists, the same thing. But the way that they sit, the place where they sit, and the way they force the GABA A to open is somehow different. But anyways, they are the same as the mechanism of action of benzodiazepines. What is the difference then? Barbiturates, can I use them for sedation and hypnosis? Yes, they can be used as sedatives and hypnotics. So the answer is always yes, because all classes we're going to talk about today are sedatives and hypnotics. Can I use them for seizures? Also yes. So barbiturates are a very good class used for seizures. What else can I use these drugs for? Can I use them as muscle relaxants as benzodiazepines? No, this is a difference. Okay, they just don't do that effect for some reason. They just don't do that.
Okay, so I cannot use them as this effect. Let's hope now that the lecture opens. All right. Okay, so this is also for barbiturates. When we want to compare the classes together, benzodiazepines and barbiturates, which one is more dangerous or has more risky addiction potential?
Barbiturates.
Barbiturates. Benzodiazepines are safer. What is my concern? Remember, guys, those are controlled drugs. So I have to be careful for patients taking them. What does this mean? If a patient is taking them, they might be at risk of addiction, مش بس هيك overdose. And what's the problem with overdose with these drugs? What does it cause? Permanent sleep, exactly, permanent sleep. So for patients, the problem usually comes from respiratory depression. So the centers of the brain will be shut, centers of breathing in the brain will be shut, and the person will undergo respiratory depression. This is what I'm scared about. But let's compare barbiturates with benzodiazepines. Which one might cause this effect more? And we said barbiturates are more dangerous, so they can cause this effect much more. So this is number one. The benzodiazepines, can they put a person into a coma? You know, for a person to reach a coma, there has to be some levels. So number one, the first person will feel slightly sleepy, so calmer, then sleepy. Increase the dose slightly, the person will sleep. Increase the effect more, dose more, the person will start having the effect that they're, مثلا, sleep usually, guys, when we say sleep, yani when you wake the person up, they're gonna wake up. But anesthesia is person unconscious. They cannot even wake up. They go into anesthesia and they go finally into coma. So when we compare benzodiazepines and barbiturates, which ones can usually cause this effect of coma? It's only barbiturates. Benzodiazepines do not have this effect. All right? All right, just give me 1 second, guys. I'm trying to open the slides for you guys, for you to see. Yeah, they finally open. Let me just come and upload the slides for you on Canvas meanwhile. Just 1 minute. I'm having an issue with the, I don't know, there might be a viral infection to my laptop. The lecture refuses to open under any circumstances. Okay, so ما بعرف what's wrong. I restarted my laptop once. Let me see if I can do something from my phone. So guys, you can all have access to the link on Teams. Everyone here? Yes. Let me try to share the slides with you on Teams, okay, so that, thank you. Central nervous system. Okay, so for now, guys, everyone, please go to chat. Okay, and I shared the link of the lecture so you can upload it. Okay, and meanwhile, I'm going to, can you all access? Yes. Okay, amazing. Yalla, and meanwhile, I'm going to share my presentation with you guys. This is the only solution. If it works, then it works. All right. I think now the slides are on Teams. You can see them. Sorry? People on Teams, can you see the slides?
Yeah, yeah.
And for those who want to take notes, you can you have them, and please just make sure that you take notes or follow with me just on the slides on Teams. All right? Yeah. So, as we said sedatives and hypnotics. Slide number 1, sedatives and hypnotics. We said which one is the one that causes sleep? Hypnosis, right? Hypnotics and sedatives are the ones that calm down a person with anxiety. All right. So remember, guys, usually when a person sleeps, they go into stages of sleep. Okay, so there are stages. You're gonna see that there's one stage called the rapid eye movement. Okay, there's a big science for this. Okay, I wish that we had time to tell you more about some feelings that you have. Just gonna tell you one example about things that you might feel. يعني مثلا sometimes when we're at the beginning of our sleep, you feel yourself, right? مثلا if you're playing مثلا a game before you sleep and you played it for too long, and then you at the beginning of your sleep this might come into your head, or something that you have thought about might come into your head at the beginning of the sleep. Okay, but at some point, even if you dream and you wake up sometimes startled, okay, so like scared because you saw yourself dropping from a far place, from somewhere that's high. So these feelings, and usually you wake up and you do a reaction. Okay, at the beginning of your sleep, your body and mind are still connected. But when you go into very, very deep sleep and you start dreaming, usually your body does not react. This is because your body puts an end to the connection of this. So your mind now is very active, still active, but it does not give order to your system to do a reaction. Okay, so these are things that are interesting to know about. Some people who sleepwalk will, their body is going to react, or this mind to muscle connection will still be there. So this is why usually they wake up and they sleepwalk, because even when they're sleeping, their body's still connected, their muscles are still connected and still can do some actions, okay? So this is in brief, the science of sleep. What do we call when a person cannot sleep? The person is having insomnia. Excellent. The person is having insomnia. Now, we said that the drugs we're going to talk about, the major 2 classes, how do they act? They act on GABA A receptors that are chloride receptors, and those are GABA A agonists. Guys, everyone on Teams, please, I want this lecture briefly, and I want you to follow my lead. So whatever I'm saying is required. Everything else you can use to read and know more, but it's not going to be required in the exam. Okay, so guys, there is a slide, okay, that shows 2 curves, one for benzodiazepines and the other for barbiturates. And you can see on the left, you see sedation, hypnosis, anesthesia, coma, and death. So which of the 2 classes is easier for me to reach? Death and coma. Barbiturates or benzodiazepines? Barbiturates. See, barbiturates? Exactly. Barbiturates is a straight line. It can go up. But benzodiazepines, it can become a straight line. Guys, can you see all of you? Amazing. Okay, so benzodiazepines, they will reach a maximum. Who's talking?
Sorry, doctor, I was.
Yes, go ahead.
You said benzodiazepines reach anesthetic effect.
Maximum, exactly. So with higher dose. So guys, it's not very easy with a high dose of benzodiazepines to cause death. And this is something that we call as a ceiling effect. What's a ceiling? A ceiling is the ceiling, right? So this is what we call as a ceiling effect. Benzodiazepines have a ceiling effect. So even with higher doses, it's harder for the patient to reach coma. But with barbiturates, there's no ceiling effect. So with high doses, the patient might reach coma. All right? Barbiturates, because of the innate nature of barbiturates. Exactly, they're more dangerous drugs. Okay, benzodiazepines, we have a list of drugs. We have so many, and I got you the brand names only for your knowledge. I'm not gonna ever ask you about the brand names. Okay, mechanism of action of benzodiazepines, you already know. I want you best to know that they are agonists of GABA A receptors. Amazing. Okay. Type. Their effect is dose dependent. You agree? The higher the effect the dose is, the higher the effect is, right? But it reaches a maximum for benzodiazepines that we call as the ceiling effect. Whereas for barbiturates, they do not have this ceiling effect. And guess what they can do as well? They can stop the breathing from the brain. Yeah, they stop the breathing centers on the brain, and the person might die because of respiratory depression. Breathing stops. So the person dies because of that. Okay? This happens more with barbiturates and not more with benzodiazepines. All right. And there's something very special about benzodiazepines only. They cause something called anterograde amnesia. What's the meaning of amnesia? Amnesia is memory loss. Okay? Amnesia is memory loss. There's something called anterograde and something called retrograde amnesia. When someone does an accident, masalan, and they lose their memory, their old memory, what do we call this? This is called retrograde amnesia. Anterograde amnesia happens when someone takes a pill of benzodiazepines, sometimes at a certain dose. They start forgetting anything that happens from now until the effect goes away. So not old memory is there. But when the patient takes the pill, they start forgetting anything that happens from now until the pill effect goes away. And this is what we call as anterograde amnesia. This is benzodiazepines. Feed drugs that actually, and this is why usually they warn people to be careful about masalan, drinking something from a stranger, masalan, when you're outside, masalan. So be careful because they can use certain types of benzodiazepines to masalan drug someone, and those are actually in the States, they call them the date rape drugs. Okay, so this is unfortunately used against certain ladies, and certain ladies were raped, and usually they forget what happens because of this drug. So this is illegal. This is why they're very controlled type of drugs. But we can also use this clinically. Masalan, when someone is having a very masalan procedure that requires you to forget, masalan, endoscopy. Endoscopy is bothersome. Endoscopy is when they insert a tube in the mouth of the person to check their stomach. Okay, so usually in endoscopy, it's like bothersome, but does it require that much intervention? So they might use this kind of drug in case the person like wakes up in the middle of the procedure, they will not remember anything afterwards. It's not a very pleasant memory. Makes sense? All right. So this is anterograde amnesia. Do you have any questions, guys? Clear? No.
Doctor,
Yes, go ahead.
can you upload the file on Canvas if you can? Yeah.
No, if I can, I would, but I can't. So this is why I sent you the link. You can save the lecture now, and then later on, I will upload the slides again on Canvas. But anyways, you have access to everything. All right?
Thank you.
You're welcome. Go ahead. Depends on the dose. Triazolam, for example, is a drug that the person will sleep and not remember. But there's a chance that the person might wake up. During the dose, that person might wake up. When they wake up, if they're there, they will not remember. And sometimes even if they're awake, they will not remember. But usually the dose, when it's intended to be given during surgery, we intend to give a dose that puts a person to sleep. That is, so that they cannot be conscious. This can happen. But usually patients who take benzodiazepines, in the doses that keep them awake, usually I've never seen someone suffer from memory loss, during the time of the dose. It starts like wearing off, the dose starts going away, and then the person will go back to having their regular memory. Yeah, it is a weird effect. Okay, so what other effects we mentioned for benzodiazepines? Seizures, muscle relaxation. We can also give it for patients who are addicted to ethanol or alcohol and want to stop. So those patients will have withdrawal symptoms. So to help with the symptoms, we can give benzodiazepines. All right. Now, I will not go into pharmacokinetics, but can we give those drugs as pills? Yes, we can. We can give the drugs as pills. And these drugs have a long duration of action, and they're actually divided according to the duration of action. And we have the ultra short acting, we have the short acting, we have intermediate, we have long acting. One of the most famous short acting drugs are triazolam, midazolam, and for long acting ones, the most famous ones is diazepam. Okay, so guys, it's not called diazepine, it's not called diazepazine, it's called diazepam, all right? So please remember this. We have to also be careful for kidney and liver. So when someone has kidney and liver dysfunction, I have to be careful about the dosing and if I need to give the drug or not, okay? All right, this is it for benzodiazepines, but I need you to remember one more thing. If a patient is addicted to alcohol and the patient takes alcohol or drinks alcohol with benzodiazepines, the effect of benzodiazepines are going to be much worse. So no alcohol, contraindicated, no alcohol with benzodiazepines for any patient. Okay, so this makes the effect of benzodiazepines worse and might cause toxicity actually.
How do we give it?
People who addicted withdrawal, yani when they stopped alcohol and they want.
Usually have problems with their liver at least.
Not all of them. Patients with liver disease, then we have to adjust the dose, and depending on how bad their liver is affected. Okay, but usually it's not only about the liver; it's about the effect, ethanol effect, and the central nervous system effect. So patients who are who take alcohol right now, and you want to give them benzodiazepines, you don't want to do that at the same time. When they stop alcohol, they're away from alcohol. Khalas, they stopped. You want to give them benzodiazepines to help them with the symptoms, yani of.
So it's not about the metabolism of the
no.
cell. So even if you are not addicted and you had alcohol with the drug,
it's very bad. Exactly. Benzodiazepines, ethanol is a very bad combination, might lead even to death. Okay, because of a central nervous system depression. Yes, Mustafa? Same effect? Okay. Yeah. You have to warn the patient. If the patient... it's not like that. They will remember that, definitely. And they usually, patients who have problems and withdrawal of alcohol, they usually will suffer from, they will have someone from their family with them usually. So you want to also talk to the family member. And luckily, you're not going to have to deal with these situations. And those are situations where you deal in rehabs. Okay, not usually in regular pharmacies. This is something more specialized. Okay. The adverse effects, what do you think? What happens to the central nervous system? Depression or excitation? Depression. So some people might have trouble when they're driving. So patients who take benzodiazepines shouldn't drive because the coordination is not 100% correct. Yani مثلا when someone, let's say a vehicle comes up and the person has to quickly press on the brakes, the coordination will not be as fast. So people are suggested not to go and drive, right? All right, and again, we said about the effect of alcohols. We talked about this. We said ethanol is very dangerous and might lead to respiratory depression. Or comparing benzodiazepines and barbiturates, which one has a higher risk of dependence? Barbiturates. But still, guys, benzodiazepines, of course, have a high risk of dependence, of course. Dependence, addiction. Okay, so they are addicted to it. Type. Stopping breathing, this is death. Exactly. So this is why this patient requires then hospitalization and cardiopulmonary support. Sometimes the heart stops. You need to recite. So it's dangerous. Yes. Shuts down the whole respiratory center in the brain. And eventually the heart is connected to respiration. So eventually, this is what we call as cardiopulmonary collapse. So the heart and lungs stop working. Okay. Time. Very briefly, guys, as rules about addiction. When we say addiction, drugs that cause addiction, the drugs that are short-acting, they will go up in the system suddenly, and they will go down in the system suddenly. So drugs that are short-acting will cause more addiction. Okay, and drugs that are long-acting will cause less addiction. So speaking of withdrawal symptoms, so when the drug gets away from the system, which of the drugs might have, do not have this withdrawal symptom? You know withdrawal symptoms? Patients will suffer from anxiety and all these bad symptoms when they stop a drug. So short term will have bad withdrawal effects. Long acting will go away from the system very slowly, so they will not have this withdrawal effects over here. Makes sense? All right. Okay, guys, I'm skipping some just some slides. So benzodiazepines, so they kill pain? No, they're not analgesics. They're only anxiolytics. So they stop anxiety, they cause sleep, but they will never cause pain to go away. So we have other drugs that are painkillers like morphine or opioids and all of these classes. Those are the drugs that are there for as analgesics. Okay, some patient, let's say, is suffering from benzodiazepine, let's say addiction. So they got an overdose and they're in the hospital and you need to save the patient. What do? Let's say benzodiazepines are GABA agonists. What do I need to do? I need to give an antagonist to stop the effect. And this is the drug, the only drug that we have is called flumazenil. Flumazenil is a benzodiazepine antagonist that can help with patients who have overdose in the hospital. صح. Those are benzodiazepine antagonists. So they go to the place where benzodiazepine binds. Exactly, same place, same allosteric sites. Excellent. All right, we're done with benzodiazepines and we talked about, yes.
Oh, sorry. This is the antidote for diazepam.
Excellent. Antidote for benzodiazepines.
Okay.
100%. Okay. Now, guys, barbiturates, you're going to see barbiturates are not that common of a drug. Okay, you're not going to see that usually in pharmacies because of the very high risk of patients' addiction, going into coma. Okay, so guys, we already mentioned the major effects. So the class is called barbiturates and the drugs are phenobarbital, pentobarbital. So guys, they're not pentobarbiturate, they're pentobarbital, not phenobarbiturate, phenobarbital, all right? And what did we say about their site? Where do they bind to? GABA A receptor, same thing. Okay, and we talked about their effects. We talked about they don't have a muscle relaxant effect, but they still have the same effects as benzodiazepines, all right? They have a higher risk of addiction, okay? So this is what I want you to know about barbiturates. They have a higher risk of pulmonary depression or respiratory depression. These are things that we already mentioned, okay? So just go back, guys, to my notes from the beginning, and this is what I want you to know. Barbiturate poisoning, patients need to take a very high dose for barbiturate poisoning, okay? And that high dose might lead the patient to go into a coma and have respiratory depression, all right? This is a table that you are also only responsible for the drugs, okay? Guys, I just want the take-home message from this lecture. I don't want any detailed information. Okay. We're done with barbiturates and benzodiazepines. Let's talk briefly about the rest of the classes. We have Z drugs. Z drugs are drugs only for sleep, okay? And depending on the duration of action, I'm gonna give them. Masalan, the first class is, okay, so guys, Z drugs are related to benzodiazepines somehow. So they act the same place, but they have different, they're only used for sleep, nothing else. The first drug is zolpidem. Zolpidem has a duration of action of 8 hours. So when do I give it? Before sleep. At 8 hours, the person will wake up okay. Mazaliplan has a duration of action of 2-3 hours. So when do I give it? When a person wakes up in the middle of the night. So let's say someone is sleeping, they wake up in the middle of the night and they cannot sleep. Duration of action is small. I give Zaliplan in this case. Makes sense? This is the other thing. Isopicolone is a long-acting one. So I need to give, and I have to be careful if the patient, I have to warn them, you might wake up the next day feeling off because that drug is very long-acting. All right, so Z drugs, guys, are drugs only for sleep. They're FDA approved, but they should not be given for a long time because also the patient might depend on them for sleep. Okay? These are the Z drugs. We're done with Z drugs. Those, isopicolone is specifically, some patients might suffer from certain diseases that require intervention, but someone who wants to sleep every night just because they cannot sleep I cannot give them a drug randomly. They're going to have dependence. Those patients, we need to give them some sort of behavioral therapy to help them with those things. Okay, that's it. So this is what I want you to know about Z-drugs. They're used for sleep, and depending on the duration of action, we can use them for specific purposes. Okay? The second class, or the class before the last class, which is called melatonin congeners. You know, have you heard of melatonin? As we said, it's the pigment of sleep. Okay? Because it's actually the gland where it's secreted is dark. Melatonin itself is a dark pigment. So melatonin is present in the market. You can find melatonin pills. Patients can take them. They're relatively safe. But again, patients can also depend on them for sleep. And they can spend, if they take them every day, they cannot sleep without them. We have melatonin itself, and we have also melatonin congeners. What do I mean melatonin congeners? Drugs that are related to melatonin. They act on melatonin receptors. What are those? We have the major one, which is ramiltayon. Ramiltayon is one of the very famous drugs that is used also for sleep. Okay? You're responsible, guys, only to know the drugs, and these drugs are the class, they're melatonin congeners. We also have a class that's called orexin antagonists. Okay, those are less famous. We have usually sevorexant, the name of the drug, and lemborexant. Those are orexin antagonists. Orexin itself is something that promotes wakefulness. So if I block orexin, what am I doing to the person? I'm putting them to sleep. That's it. All right. So guys, all of these are drugs that cause sleep. So you're going to see them. They cause sleep. But again, they're not recommended at all, of course, because they might put a person in a state of dependence. They cannot sleep without them. All right. Finally, last drug is called buspirone. Now this drug is non-sedating, does not cause sleep, but it is anxiolytic. So it's a sedative. Helps a person get rid of anxiety. All right, it's buspirone. It's called buspirone. So does not cause sedation, does not cause the amnesia that benzodiazepines do. So it's only an anxiolytic drug. It's good for anxiety and helps people with anxiety. All right. So guys, this is all I want from this lecture. I don't want any details. This is the take-home message that's important for you to know and you should remember. And this is it from this lecture. Okay. I think this lecture is worth doing a quiz in because it's easy, صح? And Parkinson's and Alzheimer's is also easy, so we can cancel them from the lecture. Let's agree that the quiz not be let me give you the option. So I was thinking let them be on Tuesday and Wednesday so that you have time to study. Or we can make them on Sunday and Monday and let's finish everything and leave the last two sessions for each section, the last session for each section for revision in case you have questions. Whoever wants to take time to study, also you have time to study. So what do you think, guys, online?
Yes, that's good. We can take it on Sunday and Monday.
Okay, so we have an agreement. Let's take the quiz on Sunday and Monday, and then we have a free session on Tuesday and Wednesday.
Yes.
Wants time to study. Whoever wants to have any question, if you want me to repeat any of the ideas, the lectures, we can have some training. Okay, we can. Autonomic nervous system plus epilepsy. 6 تقريبا.
Doctor, but we don't have a lecture on Sunday.
ليه?
We have only Monday and Wednesday.
Guys, we have two sections here. Okay, two sections are together. So for the section of Sunday, the quiz is on Sunday. For the section of Monday, the quiz is on Monday. For
okay.
Tuesday and Wednesday, if you, it's up to you guys. I'm gonna be available in class and I'm gonna do exercise on, for the exam. All right. Now, guys, I have to apologize because I have to leave now. I have another meeting. All right. And if you have any questions, I will be available. All right. Yalla. Have a good day, guys.
Thank you, Doctor.
Thank you, Doctor.
Yes.
Thank you, Doctor.
Yes.
Sorry, for the material of the quiz for Sunday, it will be only this one.
Benzodiazepines and Parkinson's and Alzheimer's. All right.
Okay.
All right. Yalla. Bye, guys.